Welcome to the Cancer Research Institute's webinar series, Cancer, Immunotherapy, and You. Today's date is Friday, July 15th, 2016. The title for today's webinar is Bladder Cancer Breakthroughs, Latest Cancer Immunotherapy News. In this webinar, we'll discuss current immunotherapy treatment options for patients with bladder cancer. Before we begin, I'd like to thank our sponsors. Today's webinar is presented by Genentech and LabAnswer and its employees, along with generous support from AbbVie, Celldex, NewLink Genetics, and Regeneron. My name is Brian Brewer, and I'm Director of Marketing and Communications at the Cancer Research Institute. The Cancer Research Institute is the world's leading nonprofit organization dedicated exclusively to exploring science aimed at harnessing the immune system's natural ability to conquer all cancers. We fund scientists around the world whose work has led to significant breakthroughs in cancer immunotherapy treatment research. Over the next 45 minutes or so, you'll hear from an immunotherapy expert about how cancer treatment is undergoing a revolution thanks to these breakthroughs, followed by a question and answer period. Now it's my pleasure to welcome today's speaker. Dr. Matthew Galsky is a professor of medicine at the Icahn School of Medicine at Mount Sinai and director of Genitourinary Medical Oncology at the Tisch Cancer Institute. His research is focused on dissecting the mechanistic underpinnings of the response and resistance to novel bladder cancer therapies, with a particular focus on immune checkpoint blockade. Dr. Galsky, we are grateful that you could take your time out of your day today to join us. Welcome.
Thank you, Brian, and welcome to everyone to today's webinar. Today, I'm going to start by discussing the role of the immune system in fighting cancer, and then I'll talk a little bit more specifically about bladder cancer. As Brian mentioned, I'm a medical oncologist, and I focus on the care of patients with bladder cancer, and that's where my research focus is as well. And about 7 years ago, we became interested in trying to use the immune system to treat metastatic bladder cancer when we launched one of the first trials using immune checkpoint blockade as a strategy for this disease. And that's really the topic of today's talk. So for the immune system to attack cancer, it first has to recognize that something about the cancer is foreign. And that foreign thing that the immune system recognizes is called a cancer antigen. We all know that when we develop infections, our immune system recognizes that pathogen, that bacteria or virus is foreign, and then mounts an immune attack to fight that infection. This becomes a little bit more tricky with cancer because unlike bacteria or viruses, cancer cells start out as normal cells, so they look much more similar to our normal cells than something like a bacteria or a virus. And that is, at least in part, why sometimes the immune system has difficulty in eradicating cancer, even though a patient's immune system might be perfectly healthy. So the immune system has to recognize something is foreign. And once that happens, a cascade of events occurs involving multiple different players in the immune system. Really, one of the first players is something called the dendritic cell. And the dendritic cell recognizes this thing that's foreign about the cancer cell, and then it goes and tells other cells that something looks abnormal, and that they should potentially go attack it. And so the dendritic cell in that way could be sort of thought of like the Paul Revere of the immune system. The dendritic cell goes to these T cells, which are really the frontline attackers of the immune system, and says, hey, something looks abnormal, you better check that out. Once that occurs, once that interaction occurs, the T cells, which again are really frontline in this attack, start to activate. They start to arm themselves to get ready for this attack. And while they're arming themselves and getting ready for this attack, they also multiply, so that there's a large number of cells which can mount this attack against cancer. And with these large amounts of cells that are poised to attack cancer, they start to travel around the body, look for cells that express these foreign proteins, and then eradicate those cells. And it's really these attributes that I've reviewed of the immune system that make this potentially a very powerful approach in treating cancer. One is specificity. As I mentioned, this immune attack is specific for cells that express this foreign protein, this antigen. So unlike conventional chemotherapy, in which sometimes there's a lot of collateral damage, when we kill cancer cells, we also kill some normal cells, and that accounts for some of the side effects of conventional chemotherapy. The immune attack against cancer is much more specific, ideally limiting this collateral damage. Another favorable aspect is durability. So when we give drugs to treat cancer, conventional chemotherapy drugs, those drugs typically work while the drugs are in the body, and then the drugs are eliminated by the body, and we have to give them again. With immune therapies, when we trigger the immune system, that immune response is long-lasting. So even when the drugs leave the body, the effects of the drugs on the immune system persist, resulting in potentially more durable control of cancer. The immune system's adaptable, so when cancer cells change, when they mutate, which is often a reason why cancer becomes resistant to conventional therapies, the immune system can recognize these mutations, these changes, as foreign and mount an entirely new attack. And finally, the immune system has memory. We all know this. There are certain infections that we only get once in our life, and then we never develop that infection again because our immune system remembers what those abnormal cells look like, and prevents us from ever getting that infection again. And the same could occur with certain cancer cells expressing certain proteins. So you might think, if the immune system's so great, why do we get cancer at all? And this is a complicated question. It becomes even a little bit more complicated in what I show on this slide. So what I'm showing here on the panels on the left are two bladder cancers, and this is bladder cancer, what it looks like under the microscope. And this is under the heading H&E, which just stands for the stain that we commonly use to stain cancer specimens and look at them under the microscope. On the right panel, we stain the same specimens for T cells, these attacker cells of the immune system. So you can see that in these two different patients' bladder cancers, in the panel on the right at the top, under the heading CD8, you can see that there's hardly any of these brown staining cells, hardly any of these T cells in that specimen. So for some reason, this patient's immune system didn't recognize something as foreign in this patient's cancer and didn't mount an attack against that cancer. In the bottom panel, however, in the bottom right, you can see that there are all of these brownish staining cells, and these are all the T cells that have infiltrated this patient's bladder cancer specimen. So the obvious question is, if there's all these T cells there, why is there cancer at all? And it's really insights into what's happening in this bottom panel that have led to some major advances in terms of using immunotherapy to treat cancer. And what specifically I'm talking about is some very smart immunologists determined or discovered that the immune system has all of these checks and balances. And these checks and balances are in place to control the amplitude and duration of the immune system. And it's pretty obvious why the immune system might need these checks and balances. If you get an infection and the infection is cleared, you want some way that your body can turn off that immune response. Otherwise, the immune response will keep mounting this attack for something that's not there. But cancer cells are smart, and they find ways to co-opt these mechanisms that the body has. And so cancer cells can upregulate these checks and balances, these immune checkpoints, and tell the body or trick the body into turning down the immune response, even though those cancer cells are still present. And these checks and balances are called immune checkpoints. Some of these immune checkpoints are PD1 or Pdl One or CTLA4. And these smart immunologists said, if this is happening, then maybe we could develop drugs to block these molecules and tell the body's immune system, no, they shouldn't dampen the response. they should continue this fight against cancer. And there have been a number of strategies to block these checkpoints that have been explored in the clinic for the treatment of a variety of different types of cancers. And today we're really going to focus on ways to block PD-1 and Pdl One. This has been an important story in cancer in general. As I mentioned, these drugs have been explored across a variety of different cancers and have shown benefit in a variety of different cancers. But this story in bladder cancer has been particularly meaningful, and it's been meaningful for the reasons that I display on this slide here. So this slide shows new drug approvals by the FDA for the treatment of genitourinary cancers over the past few decades. And in orange, you can see new drug approvals for prostate cancer by year in the cumulative number of drugs that have been approved over the past few decades. In red, you can see the new drugs approved for treatment of kidney cancer. And in green, the new drugs approved for the treatment of bladder cancer. Until just a few months ago, there had been one new drug approved for the treatment of bladder cancer in a period of approximately 30 years. And that's why the use of immunotherapies in this disease has led to significant enthusiasm. I'm going to start by talking about atezolizumab in bladder cancer. And atezolizumab is one of these drugs that blocks these immune checkpoint molecules, although there are others, and I'll touch on those as well. So atezolizumab is an antibody. It's a drug that blocks Pdl One, and atezolizumab was studied in a clinical trial called the IMvigor210 trial. In this trial, it enrolled 2 cohorts of patients, and I'm going to talk about these in reverse order for reasons that will become obvious. Cohort 2 enrolled 310 patients. And these patients had metastatic bladder cancer, so bladder cancer that had spread from the bladder to other parts of the body. And all of these patients had received prior chemotherapy, and their cancer had subsequently progressed, had subsequently grown. The primary goal of this study was to see the effects that atezolizumab had on the cancer and on the patient's body. And the main goal was to see what proportion of patients treated with this medicine had a shrinkage of their cancer as visualized on CAT scans. The drug is administered intravenously, and it's administered once every 3 weeks. Notably, the likelihood of tumor shrinkage on this study was correlated with whether or not patients had increased expression of the target for this drug, Pdl One, in tumor specimens prior to treatment, prior to the initiation of treatment. So if a patient had a tumor specimen that had high levels of this Pdl One protein in their tumor specimen, then their likelihood of having major tumor shrinkage with this drug was 28%, and that was versus 9% if there was no expression of this protein in their tumor specimen. These numbers are clearly lower than we would like them to be, but these results were still met with a lot of enthusiasm for really 3 reasons. One reason it has to do with the context in which these results need to be viewed, and unfortunately we've had very limited other treatments for patients in this disease state previously, and so these results are certainly more encouraging than what we've seen with drugs tested in this setting in the past. The second reason is that when patients respond to these medicines, the responses tend to last quite long and longer than we've seen with conventional chemotherapy. How long do the responses last? Well, we don't know the question. We don't know the answer to that question fully because at the time that the data was reported from this trial, the vast majority of patients who were responding to treatment were still responding. And the third reason why there is enthusiasm about this class of drugs is that while these drugs are certainly not without potential side effects, the side effect profile of this treatment tends to be much more favorable than standard chemotherapy. The side effects with PD-1 and Pdl One blockade have to do with its mechanism of action. So the side effects are quite different than traditional chemotherapy and have to do with this activation of the immune system. So there are a variety of itises referring to inflammation that can occur with immune checkpoint blockade. And this includes colitis, which is inflammation of the colon, and that typically manifests as diarrhea. Pneumonitis, which is inflammation of the lungs, which typically manifests as cough or shortness of breath. Dermatitis, inflammation of the skin, which is a rash. Hepatitis, not the viral hepatitis that you might think of, hepatitis B or hepatitis C, but this is an immune hepatitis leading to inflammation of the liver, which can elevate the liver function blood tests, and there can be effects on the glandular system as well, like alterations of the thyroid gland function. When these side effects occur, and when they are moderate or severe, they're generally treated with steroid medicines like prednisone. This table shows the likelihood of side effects in cohort 2 of the atezolizumab study, and in the first column you can see a variety of different side effects, and in the column in the middle and on the right are the severity of these side effects. And when we do clinical trials, we grade the severity of side effects based on pre-specified rules, and grade 3 and 4 represent the most severe side effects. So you can see here that the frequency, that the likelihood that patients developed a severe side effect on this treatment was quite low. And when we focus in on these side effects that have to do with activation of the immune system, these immune-related side effects, and those requiring steroid treatment, you can see that the frequency of side effects requiring steroid treatment are really quite low on this study. Based on these results, the FDA approved atezolizumab for the treatment of bladder cancer a few months ago. And this approval is for patients who really met the criteria for enrollment in this cohort. So patients with bladder cancer that has spread to other parts of the body and has progressed despite standard chemotherapy. There was another cohort of patients enrolled on this study, and this was cohort 1. And cohort 1 enrolled 119 patients who had metastatic bladder cancer, similar to the other cohort, cancer that had spread to other parts of the body. But in this case, patients had not received any standard chemotherapy yet. And these patients were considered cisplatin ineligible, which refers to the inability to use one of the standard chemotherapy drugs, cisplatin, that we use in bladder cancer because of concerns about its safety in this patient population. Why would someone be cisplatin ineligible? Well, a common reason is because there is some impairment in their kidney function at baseline, and cisplatin can potentially worsen that kidney function. It could be that they have a decreased functional status, meaning that they're not up and about and active as much as they used to be. Or it may be that they have hearing loss, because we know cisplatin can potentially worsen hearing loss. This study enrolled 119 patients, it's mentioned, and importantly, over 20% of patients were over 80 years old in this cohort, and this does really speak to the demographics of this patient population and somewhat also to the tolerability of this class of medications. In this group of patients, 24% had a major shrinkage of their cancer on scans, with 7% having a disappearance of the cancer on scans, what we call a complete clinical response. Interestingly, the responses in this cohort did not correlate as well with the expression of the protein Pdl One in the baseline tumor specimens. And the side effect profile is very similar to what was experienced in cohort 2. So the results from this cohort, from this study, were just reported recently, and this certainly does raise the possibility, will the treatment of bladder cancer with immunotherapy as first-line treatment become a standard in the future? And that remains to be seen. The FDA approval for atezolizumab, again, is for patients who've had already received standard chemotherapy. There are a number of other PD-1 and Pdl-1 inhibitors in development with rapidly accumulating data for the treatment of bladder cancer. And in this table, you can see a variety of different PD-1 and Pdl-1 inhibitors, the number of patients who have been enrolled on the clinical trials that have been publicly reported to date, the target, whether or not the drug is a Pdl-1 antibody or a PD-1 antibody, and the percentage of patients that had a substantial shrinkage of their cancer when enrolled on these clinical trials. You'll notice that these numbers, that these percentages differ somewhat from study to study, and this has to be viewed in the context of the size of the trials, because we know as clinical trials get bigger and bigger, our ability to precisely estimate the proportion of patients having a benefit becomes better, and so oftentimes as trials get larger, that number does decline somewhat. Based on the promise of these other PD-1 and Pdl-1 inhibitors for the treatment of bladder cancer, we do expect that there will be additional approvals on the horizon. The FDA has designated nivolumab and durvalumab with breakthrough designation for the treatment of bladder cancer, indicating that with promising additional results, there could potentially be expedited approval of these medications. So we've demonstrated that PD-1 and Pdl-1 blockade is promising in the treatment of patients with advanced bladder cancer that's progressed despite prior chemotherapy. And a typical paradigm in oncology is to first demonstrate that a medication is safe and potentially effective in patients with more advanced cancer, and then move that treatment earlier in the course of the treatment of the disease in hopes of having an even greater impact. So on this slide, I've shown two clinical trials that are active and enrolling patients that are using these medications in a much earlier setting. These are two clinical trials that enroll patients with bladder cancer that had been confined to their bladder, and their bladder had been surgically removed, and the patients are felt to be at somewhat high risk for recurrence based on the features of the bladder cancer under the microscope after it's removed. And patients are randomized on these clinical trials to receive an immune checkpoint blockade drug, a PD-1 or Pdl-1 antibody, or on one trial randomized to versus placebo, and on the other trial randomized versus observation. The randomizations on these trials are necessary in this context because these patients have no cancer that can be seen on scan, and a subset of these patients are cured with surgery alone. So really randomization is the only possible way to determine at the end of the day if these drugs have a role in improving outcomes in this particular setting. What about the question of whether or not we can replace standard chemotherapy as first-line treatment with immune checkpoint blockade instead? Well, this is a large clinical trial that's also currently enrolling patients with metastatic bladder cancer, cancer that has spread to other parts of the body, and randomizing patients to one of three treatments: a combination of two immune checkpoint inhibitors, a single-agent immune checkpoint inhibitor, or standard of care chemotherapy. How about determining how we can best combine chemotherapy and immune checkpoint blockade? These are two studies looking at these treatments in what we call the maintenance setting. I mentioned that the initial clinical trials enrolled patients who had cancer that had progressed despite chemotherapy, but what if we enrolled patients who had received chemotherapy and while they were still responding to chemotherapy, switched them to maintenance treatment with one of these drugs? And that's really the goal of these two clinical trials, to determine if we can use immune checkpoint blockade to maintain the response already achieved with chemotherapy. And both of these trials are active in enrolling patients. Because we hope that the benefits of immune checkpoint blockade could be extended to a much larger proportion of patients, a major focus of research efforts right now is trying to combine these drugs with other drugs to enhance the likelihood of response. And the combinations that are being explored really run the gamut from combinations with chemotherapy and radiation, and there's compelling rationale that these conventional treatments can also favorably modulate the immune system, combinations with targeted therapies, or combinations with other immuno-oncology approaches, and these include vaccines, novel immune checkpoint inhibitors, and approaches to try and deplete cells that might have an unfavorable interaction with the immune response. So thank you for your attention, and I'd be happy to answer any questions.
All right. Thank you very much, Dr. Galsky. Very, very interesting. Great to see after nearly 20 years, finally seeing drug approvals for patients with metastatic bladder cancer. But before this webinar, we sourced questions from the bladder cancer patient and advocacy community, and I'll be happy to share those with you in just a moment. But I just want to respond to some of the data that you presented specifically. So I was very interested to see that there didn't appear to be a correlation of response rate to Pdl One expression in that first cohort of patients, the treatment-naive patients, whereas it was the other way around in that second cohort. So what can you say more about Pdl One as a biomarker? I noticed in the nivolumab and durvalumab trials that the FDA breakthrough approvals, that it looked like durvalumab would only be approved in patients that have the Pdl One expression. So it's essentially kind of a biomarker. But is that really relevant?
So this has been a little bit of a moving target, and the reasons for the disconnect between cohorts 1 and cohort 2 in this regard are not entirely clear. Part of the challenge is that expression of this biomarker is dynamic, and so it can change quite quickly based on the dynamic nature of the immune system. And it's possible that these biopsies, this tumor tissue, that's not taken necessarily directly before a patient enrolls on a study, but could be from months or even years prior, might not represent what's going on in the tumor at that time. So this certainly might be a function of just that, the difficulty in actually measuring Pdl One, or it might be the fact that Pdl One expression does not directly correlate with response in all disease states. It might be more meaningful in some disease states than others.
You mentioned that there are a number of ongoing studies now looking at combining these treatments with chemotherapy and other types of therapies like targeted therapy. So do you think that through these combinations we have a chance of getting that response rate higher than the 24 and 28% that we saw in those first two cohorts that you showed us?
I really do, and I think we've already seen examples of that in other types of cancers. An encouraging presentation in colon cancer at this year's major oncology meeting showing that in a disease that previously didn't respond favorably to immune checkpoint blockade, when combined with a targeted therapy, increased that response rate significantly.
That's fantastic. You also pointed out the tolerability of these immunotherapies, especially in older patients greater than 80 years old. Can you say a little bit more about some of the challenges that patients at that age face when considering treatment options with chemotherapy versus immunotherapy? What are some of the challenges that are posed to a patient of that age?
So we try and not make decisions in oncology based on chronological age, but rather focus on functional age. And there are certainly patients in their 80s and 90s who are functionally in their 50s and 60s. And so we don't focus on age solely. But we know as patients get older, there are physiologic changes that impact metabolism of drugs, that impact the likelihood of having side effects. And so we take this very seriously when we make treatment decisions. At the same time, we know that bladder cancer is a disease of the elderly with a median age of diagnosis in the United States when patients are in their 70s. And so there has been sort of this disconnect that our best treatments for bladder cancer previously are treatments that really could only be used in a small subgroup of patients, and typically not those patients representative of the average patient with bladder cancer in the United States. In fact, when we look at population-based data, we know that a large subset of bladder cancer patients who have spread of bladder cancer aren't getting any treatment at all, and that might be because of this unfavorable risk-benefit ratio of standard chemotherapy. So while I would certainly never say that this new class of drugs is without side effects, because it's not, and I wouldn't say that it's without the potential for severe side effects, because it's not. In general, these drugs have proved to be more tolerable, with many patients experiencing few side effects, and we've certainly seen that in our elderly patients who really did not want to pursue standard chemotherapy, and that's why they were seeking clinical trials that would afford them the opportunity to be treated with these drugs.
If a patient does have one of those side effects that you walked us through, what happens? Let's say you treat with the prednisone steroid, and perhaps the acute inflammation subsides. Does that mean the patient has to leave that trial at that point, or what happens?
So it doesn't necessarily, and it really depends on the nature of the side effect and the severity of the side effect. Many of these side effects can be managed with steroids, and once the side effect resolves on steroids, retreatment can be safely performed.
Okay. Toward the end, you showed us a few larger studies that have randomized arms where some patients receive placebo, and I think you did a good job of explaining the rationale for that and why it's important that we have that. But how do you explain that to a patient who's looking for a treatment? How do you get the patients to enroll, knowing that they may not actually receive the treatment? What goes through a patient's mind, and what's that conversation like?
So the adjuvant setting, and that's what we call this setting, the adjuvant setting is probably among the most difficult conversations that I have, particularly when it comes to these clinical trials, because the standard approach in patients in this setting right now is just to monitor patients. That's the standard approach because, one, we know that a fair number of patients are already cured with chemotherapy, with surgery alone. And two, we haven't had treatments yet that have shown a benefit in terms of reducing the risk of recurrence in that setting. So when we apply treatments in that setting, we can't see anything on a scan, and we're essentially treating microscopic cancer that might or might not be present. We have no tests to prove whether or not that patient has cancer or not. When we do a non-randomized study in that setting, say we treated everyone with immune checkpoint blockade, at the end of the day, if we treated one patient with immune checkpoint blockade and 5 years later their cancer never came back, we would never know if the drug had a favorable effect or if it never came back because they didn't need treatment at all because the surgery was curative. So the only way to answer these questions, unfortunately, is with large randomized studies. I understand how difficult it is to make a decision like this with the potential to be randomized to no treatment or placebo. I recognize how unfavorable that sounds to patients. And I admire the courage of patients who are willing to make that leap and enroll on trials like this, because it is the only way that we'll get these answers and know how to treat patients better in the future.
Well, it sounds like, at least in this case, if the standard of care is just observation, you might as well roll the dice, right, and hope to get the treatment. And it's really not, you're not really missing out on anything if you get the placebo necessarily. So at least in this particular case, that's good.
I think that's true, and I did just want to clarify and make the point that we would never in clinical trials enroll patients that could be randomized to a placebo arm or an observation arm when that is not the standard of care. These trials with these randomizations are only done when the standard approach would be just to observe patients because we don't have any better data in that setting.
Right. I think that's an extremely important point to underscore. I don't think it's something that many patients that are new to this treatment experience in cancer necessarily understand right away. And so I thank you for sharing that again with our audiences. When a patient is going through treatment for metastatic bladder cancer, and the patient is aware of these immunotherapies, maybe the physician, the oncologist might not be aware or might not bring it up as a treatment option, and the patient does want to look into this. Should the patient talk to his or her oncologist, or should they be seeking out an immunologist in the cancer treatment center? Who should patients ask about these treatments?
So really the realm of systemic treatments for cancer is still the realm of the medical oncologist. And in 2016, I think it's quite appropriate for patients with any type of cancer to ask, is there a role for immunotherapy for me? And if not, if there's not now, would there be after this current line of treatment?
Okay, let's see. I'm going to look at some questions that were submitted ahead of time. Okay, let's talk about something called, pseudo progression, I guess. Is this, we've seen in other cancer types that treatment with immunotherapy may take longer for a response to be seen than you can see with chemotherapy, for instance. And in some cases on CT scans, tumors may appear to grow. And sometimes patients or in the past, patients were taken off trials before oncologists understood that what could be happening is an infiltration of immune cells into the tumor, causing them to appear larger on scans. Does this happen in metastatic bladder cancer?
So this happens in metastatic bladder cancer as seen on the clinical trials that have been done so far. It's an uncommon event, as it is in many other cancers, but it is seen at times. The kinetics of response to these drugs is quite variable. It's very different than what we've seen with standard chemotherapy. And I'm sure as a patient or caregiver, it might sound ludicrous that at times we can't tell if a patient is getting better or worse with the treatment based on looking at scans, but sometimes it's not straightforward, and sometimes only the test of time is what helps us determine that.
I've also encountered, doctors reporting that even though the scans appear, negative, patients reporting that they just feel better overall, like dramatic changes. And do you see this in bladder cancer?
We see this as well, not all that common also, but we do see that in those are the situations where it's a little bit more straightforward in terms of this decision making about potential pseudoprogression.
Let's say a bladder cancer has an autoimmune disease like multiple sclerosis or rheumatoid arthritis or lupus, or say they are immunocompromised. For instance, maybe they're HIV positive. Would those patients be eligible to receive immunotherapy?
So this is an area where we critically need more data. Patients with active autoimmune diseases, a history of severe autoimmune diseases, or patients with HIV were excluded from the majority of trials that we've done. In fact, all of the trials that we've done in bladder cancer. There is emerging data in patients with HIV, and limited data sets have been presented already in patients with other types of cancers like anal cancer, showing that there is preliminary evidence of safety. But we need much more experience. There are clinical trials going on now specifically enrolling patients with HIV to make sure that these treatments are safe in that patient population. Patients with autoimmune disease also, we need much more data. Autoimmune diseases are a large waste basket of different conditions with different severities, different treatments, and different natural histories, and different consequences if those diseases were exacerbated. So we know that treating patients who have had a history of autoimmune thyroid disease or sometimes autoimmune skin disease like psoriasis in the past that hasn't been active. We know that it's often safe to treat patients with those diseases, but we really have very limited data for patients with severe autoimmune diseases and active autoimmune diseases.
So we're running out of time, and so I guess I'd like to just close. By the way, I loved at the very beginning, you called dendritic cells the Paul Revere of the immune system. Which is very, very clever, and I think you explained that well, that they're kind of the ones out there saying, hey, danger, danger. Very, very good, and I'm going to steal that from you in one of our next publications. So let's just say on a scale of 1 to 5, 5 being, we're getting there, and we're going to see cures for metastatic bladder cancer patients in the near future. And 1 being, we're very, very far, and there's no improvement. What's your level of optimism for, let's say, the next 10 years of advances in advanced bladder cancer treatment?
So the pace of progress has been dramatic. I don't take using the word cure lightly. I certainly don't take that lightly, as most oncologists don't. And cure to me means that the disease is eradicated and someone no longer needs any treatment. And whether or not we will be able to achieve that in bladder cancer within these timelines, I don't know if that's likely to occur. Although I think there are the pieces of that puzzle that are starting to come together, and we've seen patients living with metastatic bladder cancer tremendously longer than we had in the past. So I won't say it's impossible at all, but we'll see what the timelines are. But there's tremendous enthusiasm for the many different treatment approaches that can be considered for clinical trials right now, and really more ideas and more good ideas than there are actually time and funding and patients to test these strategies at this time.
That's fantastic. One thing we didn't discuss, and it's a little known fact out there, that immunotherapy has been an approved treatment for bladder cancer for many years, and I'm talking about superficial bladder cancer treatment with BCG, which is a kind of bacterial approach that in many ways mimics the very early pioneering work of Dr. William B. Coley, whose daughter founded the Cancer Research Institute more than 60 years ago. Anyway, so with that, I'd like to thank you, Dr. Galsky, for that very excellent presentation on advances in immunotherapy for metastatic bladder cancer. And with that, I'd like to thank our presenting sponsors again at Genentech and LabAnswer and its employees, as well as thank the following for their generous support: AbbVie, Celldex Therapeutics, Newlink Genetics, and Regeneron. If you'd like to learn more about bladder cancer, immunotherapy, and to connect to clinical trials testing these immunotherapies in bladder cancer, including some of the trials that Dr. Galsky described that are presently accruing patients, I encourage you to go to theanswertocancer.org. It's the patient and caregiver information resource provided by the Cancer Research Institute. Lots of great information and resources there, so please go check it out if you're looking for information on clinical trials. Also, if you're in the New York City area on September 24th, we'll be hosting our first ever Immunotherapy Patient Summit. It looks to be a very exciting program. Availability is limited. There is no charge to attend. So if you'd like more information on that, you can come to cancerresearch.org, or you can visit the bit.ly that you see up on your screen. Finally, in August, we'll have a prostate cancer webinar presented by Dr. Larry Fong professor and co-leader of the Cancer Immunotherapy program at the University of California, San Francisco. We invite you to register for this upcoming webinar and to view other past webinars at cancerresearch.org/webinars. Thanks again for watching today. And Dr. Galsky, thank you very much.
Thank you.